Good afternoon, everyone, and good morning to those of you west of the Mountain Time Zone. I'm Raul Burciaga. I'm the Director of the New Mexico Legislative Council Service, and on behalf of the National Conference of State Legislatures, I would like to welcome all of you to today's webinar, containing Medicaid costs, moving toward Medicaid managed care. Today's webinar is the last in a two-part series on Medicaid. The first webinar was on Medicaid fraud and abuse and is available on the NCSL website. We are very fortunate to have two experts for today's webinar, Neva Kay of the National Academy for State Health Policy and Alan Bergman of High Impact Mission-Based Consulting and Training. Our webinar today will conclude with a question and answer session. Please note that you will not be identified when you ask a question, nor can other participants see what you have typed. As a reminder, you may participate by clicking on the Q&A button at the bottom right-hand corner of your screen and type in your question. Today's PowerPoint presentations are already posted on the NCSL website. The audio archive of the webinar is expected to be posted by late next week. I'm pleased to introduce our first speaker. Neva Kay is Managing Director for Health System Performance at the National Academy for State Health Policy. She has 25 years of experience in state health policy and, prior to joining the Academy, served as Director of Wisconsin's Medicaid Managed Care Program. Ms. Kay joined the Academy in 1994 as Director of the organization's Medicaid Resource Center. In her current position, she manages a number of programs and provides technical assistance to states in areas including children's health, purchasing, quality improvement, eligibility, and reimbursement strategies. Neva holds a Bachelor of Science degree in Industrial Engineering and Psychology from the University of Wisconsin. Please go ahead, Ms. Kay.
Thank you, Raul, and thank you, NCSL, for asking me to speak on this issue. As you just heard, I have worked on and studied Medicaid managed care for a very long time, and over this time I've seen it grow from cautious use, voluntary programs in a few states to becoming the dominant delivery system in Medicaid. Over half of Medicaid beneficiaries get at least one service through managed care delivery system, and there are also with proven cost savings and indication of improved access and quality. Today, the information I'm going to give you is drawn from original research and literature review conducted by NASHB, and also we have incorporated some data from CMS around the extent of Medicaid managed care. At NASHB, we conducted 7 point-in-time surveys of state Medicaid managed care policies, so we have a lot of information. I am not going to go over all of that with you, but I am going to draw from it to show you the widespread use and proven savings. First, widespread use. According to CMS data, as of 2010, there are only 3 states, New Hampshire, Wyoming, and Alaska, that use no form of Medicaid managed care, and New Hampshire is starting to implement such a program. So you can see that although we are moving ahead in Medicaid managed care, in many ways we are already there. Starting to narrow our focus in a little more, because there are 3 types of Medicaid managed care. What I want to focus on mostly today are the risk-based types of Medicaid managed care, those in which the state Medicaid agency pays a capitation, a person per month fee, to cover a defined set of services for a defined population. Now, comprehensive MCOs are those capitated programs, capitated plans that provide a comprehensive set of services. And they are what most people think of when they say managed care. They're thinking of an HMO-type managed care arrangement. And as of 2010, there were 35 states using this type of managed care. Then there are limited services, MCOs. These are entities that receive a capitation payment to provide a limited set of services, often just mental health services, just mental health and substance abuse services, or just dental services. And there were 42 states that had that type of managed care in place in 2010. Now, because Medicaid likes to complicate things, there are really 2 types of limited service MCOs, and you will see these initials in use in various places. They are referred to as either a PIHP or a PAHP. depending on whether they accept risk for inpatient services related to the conditions they target. In other words, a limited service MCO that covers only mental health services is a PIHP, the I standing for inpatient, if they cover inpatient mental health services, and a PAHP, the A standing for ambulatory, if they do not. There is also a third type of managed care that is unique to Medicaid called primary care case management, or PCCM, which can best be described as managed fee-for-service focused on delivery of primary care. Because I was asked to focus today mostly on risk-based managed care, that I have only one small thing left to say about PCCMs. I thought it was important to show you not just that it was widespread in use in terms of the number of states using Medicaid managed care, but also in terms of the number of people that are receiving services through Medicaid managed care. And that's really what this slide shows. As you can see, well over half of Medicaid managed care enrollees were receiving services through managed care in 2010. I think it's also quite important to point out that there are variations within this data. For example, thinking about 2009, you look at all types of managed care enrollees. About 60% of them are children, and just about 28% are people who qualify for Medicaid due to disability. And then if you narrow that in again, looking just at comprehensive MCOs, that second column there, the difference is even greater. If you look at comprehensive MCOs in 2009, 63% of the people enrolled in them were children, 10% were people who qualify for Medicaid due to disability. In other words, even though there's widespread use, it does currently, most of the people in Medicaid managed care are those that have less complex needs and are less costly. So moving on to cost savings and access and quality. I'm drawing information here from a report prepared by Lewin Group in 2004 and updated in 2009 because it's the most comprehensive of which I know. They looked at 24 different studies. And among their key findings were, indeed, these states have obtained savings. They've obtained a very wide range of savings, from 0.5% up to 20%. And I think what is really important from their study is that there are also some indications of potential savings from moving into the higher cost populations with more complex needs, and there are also indications that the savings are coming from where you would hope they would come from, that they're coming from better access and less inpatient hospital utilization. Looking more carefully or into a few examples of the states that I looked at, I wanted to in particular draw your attention to Wisconsin. Wisconsin in 2002 reported a savings of 10.7%, but they also reported that their MCOs outperformed fee-for-service oncology measures. In particular, they were looking at the number of beneficiaries who had at least one visit to a primary care provider and the number who had a mental health assessment. More people on managed care received a PCP visit than those on fee-for-service. I also wanted to show you the Arizona numbers because they enroll a large number of those with more complex needs, people who qualify for Medicaid due to disability. So now that we've spent some time talking about that Medicaid managed care is already widely used, you're probably wondering, what are the potential changes on the horizon? What more is there to do? Well, I think that for a number of different factors, there is a lot of change on the horizon. There we go. I'm anticipating continued expansion of Medicaid managed care that will be driven by exactly what you on the phone would expect. Unsustainable cost growth in Medicaid, relentless pressure on state budgets, and great expansions in Medicaid, number of Medicaid managed care beneficiaries. Even though there has been some indications that state revenue outlook is improving, just the sheer portion of state dollars going to Medicaid means that you are continually looking for efficiencies and cost savings. So I believe that those drivers will continue to drive expansion. But I want to draw your attention to where I think that those expansions are going to occur. It's not just moving from one part of the state to another, but also moving in ways that will increase the number of people enrolled in Medicaid managed care, the proportion of people enrolled in Medicaid managed care. So moving from voluntary managed enrollment to mandatory enrollment, starting to require more beneficiaries to enroll in managed care, covering a more comprehensive set of service. New York, for example, has expanded their package to require HMOs to cover dental services. Moving to, again, new areas of the state, but one of the reasons I refer back to that is moving from the more urban areas, in many cases, more into the rural areas. And then, of course, new population, moving into those who qualify due to disability and or those who are older. So I think it's important to recognize that where Medicaid managed care is expanding into is a new horizon. People with more complex needs, where there are fewer providers, where some of the things that Medicaid managed care did to be successful are going to be tested again. And because they're being tested again, states are continuing to develop innovations and expand the models of Medicaid managed care that they use. So, for example, multiple states are starting to implement programs to integrate care for Medicare and Medicaid eligibles. This is really driven very much. States have for a long time desired to have better integration of care for these groups. Last July, CMS offered an opportunity to states to begin doing that, to work with Medicare in order to better integrate care. 37 states have said yes, that they wish to take CMS up on that offer. It's difficult to tell how many of those will come into reality, but many of those that have said yes have also said that they intend to pursue integration through a capitated system. So I think there's lots of innovation there. States are also innovating in adding resources to their programs. For example, Colorado's Regional Care Collaborative Organizations. This is meant to be a move toward integration of services, moving toward almost an ACO model, Accountable Care Organization model. What Colorado did is it divided its states up into regions and identified a contractor in each region who will be responsible for providing a medical home care coordination, much as a traditional capitated managed care program would, but they also have hired a statewide data contractor who is going to provide the data that those regional care collaborative organizations need in order to better coordinate and more efficiently deliver care, as well as know how they are doing. Continuing to build on the theme of innovation, Missouri has developed health homes for people with severe and persistent mental illness under Section 2703 of the ACA. Essentially what they have done is they have charged at least some of their community health centers that meet certain criteria with also serving as a health home and coordinating the full package of services that these beneficiaries need. And it is notable that this includes some people who are also enrolled in HMO. More traditional types of managed care, capitated managed care, that are still innovative, were tested in New Mexico and Wisconsin. New Mexico has expanded a managed care by having a single BHO, a single HMO type, or single capitated program that delivers behavioral health services to people served by all state agencies, Medicaid, child welfare, juvenile justice. So they have expanded managed care by bringing in new populations of different agencies. Wisconsin has innovated by narrowing in. They developed a specialized MCO for children with extensive mental health needs who are at risk of incarceration, people who are very complex needs. So before I turn the floor over to my colleague, Alan Bergman, I want to close by just identifying, starting to lay the framework of a few success factors. These are things that I have seen in place in states that have really managed to reach that value I spoke of, to produce the cost savings, to improve access, to achieve quality. First of all, they have had clear goals for their program. And their goal was not limited to cost containment, but they explicitly wanted to improve access and quality and improve coordination. It's been very important to provide sufficient resources to build and oversee a strong program. Medicaid managed care can be successful, but it does bring a new player into the system, and it's important to make sure that the program selects those that are going to be able to serve the population well, that rates are sufficient to cover services, but low enough that you actually get those savings you're seeking, in the program or with a plan that will best meet their needs. And all of those activities that lead to success require resources, and it's important to make sure that those are there. And finally, sufficient time for the program to produce results. And by this I mean not just allow it to operate so that you see it changing how care is delivered, but also that building those strong programs and using those resources, it just takes time to implement a good program. And with those closing words, I would turn the floor back over to Raul. Thank you.
Thank you very much, Neva. Next, we will hear from Alan Bergman. Mr. Bergman is an accomplished executive with nonprofit community agencies and associations, as well as a nationally recognized leader in influencing the development of federal and state policy relating to best practice services and support for persons with disabilities. Mr. Bergman's career includes various leadership positions within local, state, and national nonprofit agencies and associations. Prior to his current position as a consultant, Mr. Bergman served as president and CEO of both the Annixter Center and the Brain Injury Association of America. His expertise includes policy, practice, and financing of Medicaid, Medicare, managed care, and long-term services and support. Please go ahead, Mr. Bergman.
Thank you, Raul, for that kind introduction, and Neva for laying out the broad landscape of where we've been. I similarly have been toiling in the vineyards of Medicaid since 1980, and I first want to commend NCSL, and particularly the legislative staff organization, for requesting this issue. This is a very hot issue at this time, and it's going to get hotter. I have many data slides. Fortunately, you're going to be able to download them. So I'm going to go rather quickly through a lot of what's in here, but I wanted to give you a flavor for why we're here now as opposed to perhaps in the past. And as Neva said, the new horizons of continued expansion are in front of us. We need to remember that Medicaid in 2009 served 65 million people at a total cost of $361 billion. People often say it's an expensive program, but as Rodney Whitlock, Chief Staffer for Senator Grassley, the ranking member on the Senate Finance Committee, tries to remind us, Medicaid serves lots of people, lots of diverse populations, and does lots of things. It's big. It's not necessarily expensive when we look underneath it. Most recent indication is that 71% of the participants in Medicaid are in some form of managed care, and what I would suggest, as Neva also pointed out, is that, in fact, most of what has been done to date is the low-hanging fruit. 25% of the population, mostly persons on SSI, either with disability or frail elderly, about 16 million people, account for 68% of the expenditures in Medicaid because they have more complex health issues and they do use long-term services and support. Mike Hall, who is the CMS Director for the Division of Integrated Health Systems, spoke at a conference last fall and said states' proposals can only be described as a stampede. This is consistent with the what's over the horizon that Neva was talking about. I have referred to this as an epidemic. This is on very, very fast forward, particularly using the 1115 research and demonstration waivers. Important to recognize that when we talk about individuals with disabilities, it's a heterogeneous and a diverse population. It's not one kind of person, one size fits all isn't going to do it even by diagnosis, let alone within the diagnostic label. This is a very, very diverse population, most of whom have multiple chronic or complex conditions. Wanted you to see a little bit quickly of the comorbidity, again, of what's going on with these populations and why the issues are complex and why it was pointed out even in the Lewin data that coordination and prevention of hospitalization are probably going to be where the real cost savings will occur. Recent data showing us that 1.5 to 2 to 3 times difference in the prevalence of hypertension, diabetes. We all know these are major issues in the general population. Look what happens to people with persistent mental illness and or substance abuse. Massive, massive numbers. When we look into the rates for people with cognitive limitations, again, what we see is significant disparity between people with no disabilities and people with cognitive limitations on a lot of common chronic conditions. All of it then leads to questions about the adequacy of the current fee-for-service system and what is it that we are generating or not generating as it relates to this particular population. A fair amount of work has been done recently, and I want to commend the Kaiser Family Foundation, not only for the report cited here, but for the years of work they have been doing that helps people like me, and I hope you, and others in the policy analysis world and implementation world look at data and trends and all the other things that are important and lessons learned. And this quote, I think, summarizes it all in terms of what we know about Medicaid managed care as it relates to people with disabilities. Patterns of care over time, reduced hospital use, as was alluded to in the Lewin, advanced clinical management and care coordination. And I would just say, from my experience, that's where we are. And the sad news for those of you on the call in state legislatures is quick fiscal relief is probably not realistic. And I know that's not what people would like to hear, but that's kind of where we are. So we have to take a look carefully at what works, what doesn't work, and what do we know about this particular population. And we don't know a lot. We don't know a lot. Again, pointing out with a variety of photos here, we are dealing with individuals with disabilities, each of whom brings his or her own profile to the table of what their needs are. So how should states proceed? Slowly. One of the key principles here is bringing the stakeholders to the table. These folks have real experiences to talk about. They can talk about the quality of care, the access or the lack of access, and what are all the things that are going to be necessary in a managed care or capitated structure to meet their needs and hopefully improve health outcomes and reduce costs over time. There are potential gains in those areas, but moving too quickly, there are potential risks of people actually becoming sicker and in some cases possibly even dying because of the inexperience or unresponsiveness to this particular population. As I alluded to earlier, the fee-for-service rates may not be adequate to build capitation rates on based on health outcomes and low payments, and may have to look not only at changing the rates, but clearly there have to be risk adjusters based on the severity and complexity of the people's conditions, which the actuarial firms can certainly be of assistance in at least looking at your current claims data. Probably can't do full risk fee switching to managed care in the first year because of these kinds of issues. And perhaps it is worth looking at some of the prepaid health plans where from the state's perspective there is still capitation, but potentially a lot more flexibility in how the services get delivered using an interdisciplinary team and still reducing the unnecessary hospitalizations. Care needs to be established and putting together the provider network, both in terms of specialists and subspecialists, both pediatric and adult. These are folks with complex conditions, and from my own experience, specifically at the Brain Injury Association of America, I'm sorry to report to you that one can be a board-certified neurologist in the United States and have had 1 3-hour course in concussion and traumatic brain injury. So having neurologists, for example, in the provider network doesn't necessarily mean that they have qualifications and the expertise and the experience to meet the needs of someone with traumatic brain injury, and we could do that across all of the different diagnostic groups. Care coordination, there is an incentive in the Affordable Care Act for Medicaid health homes, and Neva alluded to a few states that have begun to do this. This is what I call care coordination on steroids, and it may be one of the most exciting things available to states to look at within a capitation arrangement of making sure that nobody drops the ball. When people leave the hospital, there is follow-up and prescriptions are filled and doctor's appointments are made, and Dr. 1 and Dr. 2 and Dr. 3 talk to one another and don't give conflicting information. Lots of protections need to be put in terms of third-party appeal, a recognition that a lot of these folks have low health literacy and that the plans can't be written, the information by attorneys for folks who are assumed to have high school or college education. The more specific the contract specs can be, the better off everybody's going to be. And as Neva pointed out, and I want to reiterate, there has to be money for state oversight. The state cannot give away its ultimate responsibility. Now I want to shift to long-term services and supports, and very often people say, why is Medicaid paying for this in the first place? Well, the reason is simple. It's been in the enabling statute since 1965. Rehabilitation and other services to help such families and individuals attain or retain capability for independence or self-care. That's 1965. I guess we thought we were so excited in 1990 when we had the Americans with Disabilities Act talking about independent living and full community inclusion. We've actually had it in Medicaid law for a long, long time. So why long-term services and supports? Why the budget busters? Wisconsin is the only state I've seen that's done this, but perhaps your states have done it. I just haven't seen the information. In terms of what are we looking at over the next 2 to 5 years with the aging of the baby boomers and the changing demographic, given that Medicaid pays for 40% of long-term services and supports today. And if we look at the growth in the over 65 and the over 85 population, there's going to be massive growth in Medicaid. These are some of the slides from Kaiser that I alluded to earlier, and you can see, again, very clearly that long-term care users take care of just about half of all Medicaid spending, and this is differentiated by folks who are using community-based services or using institutional services. This is the elderly population on that same dimension, breaking it down into the two different populations. And again, pardon me, you can see disproportionality between the small number, relatively speaking, of people who use long-term care and the high cost of those long-term services and supports. Same true in the disability community. So this is big-ticket stuff. Oops. And here's another slice at looking at the dual eligible, because this, as Neva pointed out, and I'll give you some information on in a moment, is a growing area that everyone is looking at in terms of potential cost savings. And you can see that a small group of people in Medicare and in Medicaid account for a significant portion of the dollars expended in each of those programs. The Wall Street Journal has even put it on their watch. Dual patients are seen as a potential $300 billion opportunity for managed care firms. That's a recent quote. But I would also mention in 2010, the Deloitte Center for Health Solutions pointed out, and this is a direct quote, state leaders must look to promising areas where opportunities for cost savings also improve results. And again, that's going to take time. Here's a map showing the 15 states that have been granted funds by CMS for dual eligible initiatives. This is the list of states that have said they might want to do something in this area as of at least last October, and this continues to move forward. So why should Medicare and Medicaid be integrated? Well, there are some good reasons. improving health outcomes and leading to reduced costs is something that we would all want to have occur. But we've got to be careful that the incentives are lined up so that we're just not cost-shifting and disrupting care. Bad reasons, certainly we don't want to limit care in order to generate short-term saving and expand private managed care for its own sake. There's got to be undergirding of real policy and expectations from states in terms of why are we doing this. Also, again, the no one-size-fits-all. My colleague Nancy Thaler at the National Association of State Directors of DD Services put this together last month, and I don't need to reinvent it. The populations who are dually eligible are very, very different in their age, in their complexity, in the engagement of their families, what their focus is, what their care issues are, and even what the primary services are. And this is intellectual and developmental disabilities, but I think we could broaden this for most folks under 65 with disability. Habilitation, training, employment, independent, semi-independent living are the primary services, which tend to be quite different from what folks 75, 80, 85 tend to look for when they're in the frail elderly category. So as states begin to do this, and there are ongoing dialogues with Melanie Bella, who heads up this initiative at CMS, to help recognize this is not one population. This is probably several populations. Examples historically of success for dual eligibles on the elderly side has been the PACE program, or Program of All-Inclusive Care for the Elderly. The mean age in this population is 78. There are about 82 programs. But I would suggest this is not managed care as we're thinking about managed care organizations. This is capitation and an integrated care model. There are attempts to modify this in statute and lower the age. I can tell you there is vehement opposition across all the national disability organizations for the reasons I alluded to earlier about the care model for this not to occur. This works fine. It seems to be working well and is going to be expanded in a number of states for the aging population. So what do we know about the integrated Medicaid managed care plans where the medical, institutional, and home community-based services are fully covered? Again, from a report by Kaiser at the end of last year. What you can see, as was pointed out also by Neva, very few mandatory enrollments. Most are voluntary. Most are for frail elders. Most exclude people with developmental disabilities, although that's beginning to change, and we'll talk about that. And in addition, the variety of structures in which this has been done, I don't have time to explain, but these are all set up somewhat differently. On the right-hand side, we have those that didn't have full coverage, and the left side at least structures the incentives so that you can move much more toward a rebalancing and more use of home and community-based services rather than institutional services. I would commend New Mexico as an example, again, on strategically taking time. They spent 2 years building this before they rolled it out. And that is critical to having stakeholder involvement. As I understand it, they had monthly meetings with all the stakeholders in order to build this, design it, and try to set it up in a way that people would feel pretty good about it and nobody would feel that they were really getting short shrifted. Into the world of intellectual and developmental disabilities, bringing us up to date, we now have 11 states that have no institutions, none, for individuals with developmental disability. We have made unbelievable progress from 1970, when there were about 180,000 people, to today less than 33,000. Unfortunately, what you'll see here is that about 65% of the remaining institutional population is in 10 states. On the other hand, from a cost savings and cost rebalancing and shifting, these are huge opportunities in rebalancing the system that don't exist, frankly, in that first group of states and another 10 that are down to 100 people or less. they've captured and redirected those savings over the years. But as you go forward and as we go forward, we have to really look at what are the models and what are the costs, not on a yearly basis, but recently some of us took the numbers from Dr. Braddock at the University of Colorado, Dr. Lakin at the University of Minnesota, and ran some averages out 20 and 30 years. Because once somebody comes into the developmental disability system, they're in it for life, varying needs over time. Again, different from the frail elderly population, which unfortunately, as we all get there, is on a shortened curve as opposed to a long curve. Waiting lists are up, service demand is up, and limited new resources. So we have to look at what structure makes sense. And this isn't anymore just about ideology of institutions. This is about bang for the buck. As an example, Michigan, which is not a very rich state, has pretty much turned the corner. This is, again, from Dave Braddock's data. And what you will see is 89% of the people getting services and supports in Michigan with intellectual and developmental disabilities are living in settings of 6 or fewer, and of that 80% are in supported living, and I'll explain what that is in a moment. Their institutional and nursing home population of individuals with intellectual and developmental disability is almost non-existent. And the reason that happened is back in 1998 when they got started, and I'll come back to theirs in a moment, they laid out a set of valued principles and outcomes, and they spent 2 to 3 years developing this, again, with all the stakeholders about a vision for the future. Supported living basically is a radical change from the traditional provider, facility-based, controlled living situation, group homes, private or public, intermediate care facilities for people with developmental disabilities, and really changing over the focus to a lot more choice and control by the individual and or his or her family. Another area that needs to be looked at if we're going to deal with people with disabilities under 65, again, this is traditional from the intellectual developmental disabilities area, which is one of the largest expenditures in long-term services and supports, is the current fight that is going on now between sheltered work, day habilitation, day treatment, day training forever, or employment services, be they customized, competitive, or supported. And it reminds me of that old Goethe state of, do we want to give people fish for a day or teach them to fish? And there is a major initiative across the country now called Employment First. And what you see here is what has happened in supported employment in the state of Washington, again, not a rich state, where the state DD director, Linda Rolfe, took the initiative of saying, we know that most people with developmental disabilities can work, they should work. I would say it was almost a welfare reform kind of approach, and you don't get the luxury, even under choice, to say, I just want to go to the day hab program and hang out with my friends at public expense. First is employment, and you see here that 62% of the people in their 1915C Home and Community-Based Services waiver are in some kind of paid work. And then when they're not working, they don't go hang out in the day place. They're doing meaningful participation in the community. Vast disparities across the states. You can see where yours is. I don't have them all here. And Washington from 2009 to 11 went up to 72%. Some states are doing this well. Some states have hardly started. And this is a political will issue. This is a performance outcome issue. This is an incentive issue. It's, again, do you want to keep paying the same bills forever and ever, or maybe invest a little more on the front and then save a bunch later, plus improve people's quality of life? Managed care specifically in the IDD, long-term services and supports world, is also under rapid development, as you can see by the asterisk states. These are the ones that I know about based on calls, places that I've been doing some consulting. But the stalwarts of this have been Arizona, Michigan, Vermont, and Wisconsin, all with a 10-year history. And That's what I'm going to focus on in my remaining time. Wisconsin started their family care in 1999, and again, it's been phased in. And due to budget cuts, it has not been completed yet this year. It was online this last year, but that's been held up. I think there are 5 or 6 counties that have not yet converted. And as I point out to you, the lessons learned here, they're going to be different because we need to remember that every state's history is different, its culture is different, its current provider mix and distribution of resources is different. But they did go to family care as a capitated managed long-term support piece in '99, and they primarily built on the Aging Disability Resource Centers and managed care organizations that have been created from the ground up, mostly nonprofit organizations. But this has raised an issue because last year the state legislative auditors did a study and found at least 3 of these organizations were insolvent or on the borderline of becoming insolvent because they weren't set up in the same standards as an insurance company in terms of risk, solvency, and reserves. Benefits in Wisconsin, they've ended their waiting list. Part of the arrangement they made, and they used the 1915B-C combo with CMS, is that over time everybody gets in, which means your unit cost is going down. No different from Michigan, fundamental set of values as the foundation for how to build this system, and the primary goal was not cost containment or cost savings, but they knew if they did this, they would actually save dollars, and they have. There are lessons to be learned, and again, this is from their own data. Rapid expansion over the past 3 years, this was before the budget freeze, has led to growing pains. One other thing they did in Wisconsin as part of the statute creating this is they did establish an independent ombudsperson program as an important system component, and from talking to people in that state, this has been very, very worthwhile. Less than a dozen cases have had to go to the state agency for resolution. They have all been negotiated and resolved through the ombudsperson. Not to be undone, however, CMS said, in the name of self-direction and consumer empowerment and control, you've got to have an alternative to family care, and so they created the IRIS program, Include, Respect, I Self-Direct, and that is a self-directed supports waiver done strictly with an independent consultant agency or broker and fiscal service agency, kind of looking like some of the work of cash and counseling, but again, greatly expanded. This is the menu of how people can use the money within their individual budget. And this is some of the outcomes that the state believes they have seen and what they want to go forward on. More consumer-directed care, people living as independently as possible, but assuring health and safety, dealing with family, youth in transition, more informal supports, less intensive wherever possible, ensure employment are in the person-centered plans which are required, and focusing on youth in transition coming out of school with functional living skills and jobs, so they need much less support when they hit the adult system front door. And lastly, we have Michigan. This is an example from one of the mental health boards. Again, they've been doing this since 1998. CMS has renewed it 4 times. It's a total carve-out of Medicaid, mental health, substance abuse, and DD services from health services, 46 public mental health boards. And the primary reason they used, we're thinking about, is because health plans don't provide residential, supported living, vocational, community treatment, where most of the dollars are used. So the design in Michigan was to carve all of that out and put it into the mental health boards. I give you the example from this one particular agency in Detroit, and important to look at what's happened to their net revenues. This is millions, actually. And you can see that over 7 years, it went up and down, but they now have the same amount of money they had in 2004. yet the number of people are up. So the per member per month revenues, the third line, are down significantly. And what's happened here is they've continued to reduce their administrative overhead in this particular organization to 3.6% rather than squeezing it out of services. So what's happened there? What have they transformed that could be a lesson to be learned in terms of the model? They've moved to the individual budgets, and you can see the dramatic change over 12 years. Most recently, Ohio and Pennsylvania have had new waivers approved by CMS that will be implemented July 1st, building off of this type of experience with individualized budgets. Here's the transformation. Some of you on this call maybe have been around as long as I have, when we used to have the red line being the state institution and the blue line being the 1915C Home and Community-Based Services waiver. This is the new transformation. The number of people living in licensed group homes has dramatically changed, and the number of people living in their own home with supported living that we discussed earlier has risen phenomenally. Also, how many people live with how many people? Most states it's been 8 in a group home, 6 in a group home. This is a dramatic shift. The vast majority of people now in Michigan in this particular catchment area are living in a setting of 4 or fewer, probably about 80%. And that's pretty significant because that changes your costs, it changes your control, and it changes how you go forward. In my remaining 2 minutes, quick policy recommendations. Stakeholder engagement and ongoing involvement, absolutely essential. Clear vision, mission, guiding principles, core values with incentives to support those. A rate-setting methodology that also has incentives and that is transparent. Performance measures and metrics are hard to find. HEDIS, which is our health measures, just came out with 7 measures just in the area of schizophrenia and bipolar disorder. We've got a lot more work to do here in terms of what to incentivize and what to measure. What kind of waivers are you using? The feds have a whole menu, and the state can never abrogate its responsibility, but if it's going to capitate, it needs to do its regulations in a way that are user-friendly. The financial risk issue I mentioned earlier, the specs and the requirements for the managed care organization, what kind of expertise do they have to bring to the table, and there's got to be real time in the health information area when there are issues that need to be addressed in terms of health, life, safety. One cannot overlook the Olmstead Supreme Court decision and the integration mandate within the Americans with Disabilities Act. The Department of Justice has been very, very active now about what is segregation, what is integration. Last year they took on sheltered workshops under this in the Commonwealth of Virginia, and they're probably going to be doing that in some other places. When we get done, it's all about work and play, friends in the community, and real people. And I would suggest to you that perhaps William Gibson, a science fiction writer, may have had it right. The future is already here. It's just not evenly distributed. And hopefully some of these lessons can be applied elsewhere. Thank you, and I'll turn it back to Raul.
Thank you very much, Alan. Appreciate that. Those were excellent presentations, so thank you again, Neva and Alan. Now, I have to apologize because we seem to be having some technical problems, and I think some people have not been able to submit questions. I've gotten some, but I think other people may be having problems, so I apologize. First, a couple of clarifications. Number one is the PowerPoint presentation. These slides are already available on the NCSL website. Additionally, the recording of this webinar will be available most likely by the end of next week. Third, if you have any questions that you can't get through now, please email them to Melissa Hanson at NCSL. And the slides that are on there, as I said, are I think in a PDF format on the NCSL website. But I did pick up some questions, and one of them has to do with just the overall growth of Medicaid. Alan or Neva, do either of you have an estimate as in terms of how much Medicaid is going to grow over the next few years or decade, and how does that compare with the growth of the private insurance market? Alan or Neva, either one of you have a?
I'll take a shot at it. I'm sorry, Neva, go ahead.
I was just going to say that I don't have the numbers close at hand, but considering, depending on what happens with the Supreme Court and other things, there would be a significant expansion potentially of the number of people enrolled in Medicaid coming up in 2014, when there would be a requirement to expand coverage for mostly adults. And so I think whatever the decision is there will have a huge impact on the number of people covered in Medicaid.
Yeah, I would just add to that if that happens, that's a big boost to the growth of Medicaid federally and state. For the first several years, 100% federal, and then phasing down to 90% federal, the remainder to states. But the other thing is what I pointed out earlier is the growing demographics on the aging side, and the fact that Medicaid currently constitutes 40% of long-term services and support, and that population we know is going to continue to grow, and as a result, that will have an impact. The other thing that we don't know is how long the recession will last, because one of the big growth factors the last several years has been that as people have lost their jobs, they have unfortunately been low enough income to qualify for Medicaid. So there's an unknown here about the recession and where that will impact over the next 3 to 5 years. But clearly Medicaid's on a growth curve under the best of circumstances.
Thank you. Alan, one of the questions I think is kind of directed at you. You talked a lot about moving to managed care and how it's important to involve stakeholders. One of the participants was wondering if you could somehow define stakeholder. I mean, I know it varies from state to state, but define, if you will, or talk about the stakeholders that should be consulted.
Sure. Well, first and foremost, and I'll do it in 2 parts, although I think they're overlapping. Let's start with the long-term services and supports. I think it's absolutely essential that the end user or the customer or the consumer, whatever language we want to use, who are currently getting those services and supports be at the table, that the existing providers be at the table, that the programmatic agency, whether that's developmental disabilities or aging or senior services or mental health or mental illness, whatever it's called, be at the table along with the Medicaid agency. That the people and many of the other providers on the healthcare side, if there are primary care or clinical care coordinators in healthcare, an example I'll give that's causing problems in a couple of states now is major children's hospitals are seen as a repository of great capacity and talent for children with complex healthcare needs, chronic health conditions, and disabilities. There are some states that didn't spell that out in the specs for the managed care organization, and they are yet to sign on in the provider network. That's absolutely devastating. If you've been in that system for 10 years, 20 years, 30 years, you know the team, they know you, they know your kid, they know the adult. And so I think that's the other part that's critical here, is to bring in the current providers, be they medical, clinical, or long-term services and supports, to at least talk about what they've done, how they've done it, and what are the lessons to be learned. And I think this could also be very instructional to potential managed care organizations who think they want to bid on this work when the state puts it out to bid.
Thanks. I think I've got one more question before we wrap this up, and this has to do with the people who are living in their own homes, home and community-based waivers. Is that only people living in their homes? Is that only part of a waiver plan, or can that be part of a state plan?
There are actually ways to do that as a state plan. There is a whole self-directed care option, 1915J, I think, without looking up in front of me, so that there are ways to do that for folks if states wanted to pursue that. And I'll be happy to get that specific citation to NCSL to put out after this.
Great. Again, I'd like to thank today's presenters, Neva Kay and Alan Bergman, as well as NCSL. We do apologize for any technical problems that anybody may have had. Again, if you have any follow-up questions, you can send them to Melissa Hanson at NCSL. Thank you, everybody, attendees and presenters, for your time and participation in today's conference. Thank you all very much, and have a great weekend.
Thank you.